If you are careful about choosing the brand from
Yeah.
a good company, then it benefits. Friends, today we have a special webinar. We'll be having two speakers. The whole webinar revolves around Venetoclax. I'll be the first speaker, and this will be followed by Dr. Priyanka Mehta from London, UK. As usual, this webinar is brought to you by Mumbai Hematology Group. Today's webinar is supported by AbbVie and Lucian, managed by Perfect Square. I'm grateful to Team AbbVie and Lucian, Yash Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, and our guest speaker from UK, Priyanka Mehta. All our discussants are themselves eminent hematologists and medical oncologists, and you participants for sparing your Friday evening. Next Thursday at 6:30 p.m., we have MDS by Surgeon Commander V.A. Arun, and we have chronic ITP in pediatrics from Dr. Neeta Radhakrishnan. I'll be giving you the first talk. The first talk is about Venetoclax in chronic lymphocytic leukemia, advances, challenges, and perspective. Can I have my slide deck? Okay. So managing chronic lymphocytic leukemia in 2026, an update with Venetoclax, advances, challenges, and perspectives. So the outline of my talk will be, first we look at the CLL pathophysiology and the biomarkers. Then we'll discuss the shift from chemoimmunotherapy to targeted therapies. Then we will go to the mechanics of frontline fixed duration regimens. We'll see the pivotal clinical trials and the data, how to manage the toxicities and especially the tumor lysis syndrome. We'll talk about the strategic patient selection and a little bit about the futuristic views. So there are three fundamental changes which have occurred in the management of CLL in 2026. The treatment of CLL has evolved from traditional chemoimmunotherapy, that is bendamustine rituximab or FCR, to now the precision targeted medicines, which include the BTK inhibitors, the BCL2 inhibitors, and others, chiefly the monoclonals. The second fundamental change has occurred is we are moving from the continuous BTKI to a fixed duration therapy, which is based on BCL2I. And this is giving freedom from the long-term intervals. I mean, you can equate it to the chronic myeloid leukemia, where we talk about the TFR. Here we talk about TFI, the treatment-free interval. And the third major change that has occurred is that now we give importance to the patient and optimize our treatment based on the patient-centric approach. Within fixed duration protocol, also we have options. And the patient profile will be most important in deciding which particular combination would you use. Looking at the epidemiology, demographics, and prognosis of CLL. The median age of this disease in the Western world is 70. The same in India is 60. But 60 or 70, you invariably have patients who have comorbidities. Diabetes, hypertension, dyslipidemia, ischemic heart disease, some have stroke, some have pulmonary problems, some have poor kidney function, so on. So many patients will have comorbidities which you have to respect in selecting your protocols. Overall, with the modern targeted therapies, the overall survival has dramatically improved, and it is over 90% at 5 years, which is equivalent to the normal survival at this age. Talking about the biological and the genetic biomarkers, all of us have access to the FISH test, and the four fish test that you look at is deletion 17p, which has a detrimental outcome, especially with chemoimmunotherapy. Deletion even Q, which is better than deletion 17p, but not as good as trisomy 12 and the best deletion 13q. The second thing we all look at is the TP53 gene aberrations. This is done by NGS technique and it is quite independent of the deletion 17p. You may not have deletion 17p, but you may have aberrations in the TP53. And the last thing which is unique to CLL is to look at the IGHV mutational status, because unmutated IGHV has a poorer prognosis than the mutated. So if you got deletion 13q, you do not have a TP53 aberration. And if you got a mutated IGHV, then you got the best of the combination. The question that you ask yourself today is the era of chemotherapy-based treatment for CLL over? So fludarabine, cyclophosphamide, rituximab, the FCR protocol was the frontline standard protocol for a young fit persons for long. I remember in turn of the century, this was the most popular protocol we used for a fit young person. This is almost obsolete today. I haven't used it for last 15 years whatsoever. It got replaced by safer and easier to use bendamustine rituximab. It initially came for older, less fit people, but it got used for everybody, including young fit people, because of its ease, safety. In India, I can't say that BR is obsolete, but in the Western world, overall chemoimmunotherapy is obsolete, so bendamustine rituximab is also not used. The reason for that is that CIT relies upon the non-specific DNA damage. And this leads to significant long-term toxicities, causes myelosuppression, secondary cancers. And all these are way beyond when you use the targeted therapies, which is relatively free from these problems. So CIT has inferior progression-free survival across the patient's risk group. It's not just deletion 17p or TP53 mutated. It's across the patient group. The outcome of CIT is inferior. And there is a higher risk of treatment-related MDS and AML. The present targeted therapies are free from this. In TP53 mutated CLL or deletion 17p CLL, not only chemoimmunotherapy is ineffective, it is detrimental. It shortens the life. So if at all you want to use bendamustine rituximab for anybody, one thing you must do is to exclude these patients. Here comes the entry of the targeted agents and the targeted era. And the first of this was the BTK inhibitor. And this was a continuous BTK inhibitor protocol. It was a total revolution, moving from FCR and BR to a continuous BTKI. First was ibrutinib. The production of ibrutinib is almost halted because it is replaced with a safer acalabrutinib, which will sooner or later get replaced by still safer and more potent zanubrutinib. So these are the three BTK inhibitors one talks about, of which ibru is no more produced in large part of the world, including India. So you've got only acala and zanu. And both are available in India. These drugs block the B-cell receptor survival signaling. And what they do is to force the malignant cells out of the protective niche, like the spleen or the liver or the marrow, the lymph nodes, and they come out into the peripheral blood. Therefore, when you use acala or zanu, there is a lymphocytosis which worsens. Somebody's got 50,000 lymphocytes, it goes to 100,000, 200,000, so on, because there's a movement happening of the lymphocytes from these niches. These drugs, the BTKIs, acala and zanu, have achieved unprecedented durable remission. But the problem is that these drugs have to be continued indefinitely. They have to be continued continuously, not in a cyclic fashion. And they have to be given daily, once or twice a day. Both the present BTKI are twice a day, Acala and Xano. Xano can be used once a day, but because it comes to 4 capsules, it is still used 2 BD. And these have to be continued unless they stop failing or they produce some side effect which is not tolerable. So this is targeted therapy, continuous BTKI. So there are pitfalls of this kind of continuous indefinite therapy. And the challenges or the pitfalls include cumulative toxicity. So these are low-grade persistent adverse effects. If you see the graph, gradually the incidence of atrial fibrillation increases, which is one of the major problem with BTKIs. The incidence of hypertension keeps going up. Bleeding, bruising can occur. Arthralgia can be significant, and not mentioned here, fatigue and diarrhea can be bothersome. When you have to take a compound lifelong, for years and sometimes for a decade or more, there's a lot of financial strain, especially if it has to be from the out of pocket. Like in India, oral drugs are not reimbursed by insurance companies. And the worst is that this leads to clonal evolution. The continuous selective pressure drives the development of secondary resistant mutation, the commonest being the 481. So that brings us to now fixed duration therapy, targeted therapy, which are time limited. Now, these are designed to hit the clone very harder and deeper. And these are used usually in combination, not as a single drug. Like BTKI was a single drug. Here, it's always a combination. And because it hits the clone hard and deep, it achieves a deep clearance. In the sense, the MRD becomes negative, which doesn't happen with the continuous single drug BTKI. In clinical practice, one doesn't even look at the MRD at the moment, at least in 2026. The treatment is deliberately stopped as a predetermined time point. For example, if it's a newly diagnosed patient, 12 months and stop. If it's a relapsed refractory patient, 24 months and stop. So you don't look at the MRD to decide when to stop. And that is possible because it achieves a deep remission, at the end of which, when you stop the drug, irrespective of the MRD, you get a very lengthy treatment-free interval, which is to the tune of median of 5 years. Now, if you compare the continuous versus fixed duration therapy of CLL with these targeted agents, continuous therapy is a suppressive therapy. And therefore, it is continuous daily pressure on the clone so that the clone does not re-emerge. While fixed duration, you are eradicating the clone to the deepest possible, maximum possible extent within a short period. As was mentioned, 1 year for the newly diagnosed, 2 years for the relapsed patient. And patient preference is strongly tilting towards the fixed duration option because he wants to escape from this continuous daily medication and the side effect and the financial toxicity of continuous daily medication. So this is the comparison between continuous BTKI monotherapy versus a combination therapy, which is Venetoclax based fixed duration therapy. So BTKI based continuous therapy is until disease progresses or there is a toxicity, while Ven plus therapy is for a predefined period of 12 to 24 months. With BTKI monotherapy, continuous therapy, there is nothing like undetectable MRD, while Ven-based combination fixed therapy produces very high rate of undetectable MRD to the tune of almost 50 to 70%. The toxicities of BTKI monotherapy are cardiac, basically atrial fibrillation, hypertension, and bleeding. Now, that of Ven-based fixed duration therapy is Ven-related neutropenia, which is manageable either by halting the drug for a period, decreasing the dose of the drug, or giving GCSL. There is an issue of tumor lysis syndrome, which is manageable, which is preventable. We'll see that. And if you're giving Ven in combination with obinutuzumab, then there are infusional toxicity if you're not careful, which for a hematologist is peanuts because you know how to prevent the infusional toxicity. And lastly, the resistance pattern. With BTKI, you sort of drive into a selective pressure mutation like 481. While with Ven-based fixed duration therapy, there is very little risk of the resistance. As a result of which, after 5 years or 7 years, if the patient has got his disease back, you can use the same drug, the same Venetoclax Acala or Venetoclax Xanu or Venetoclax Obinu or Venetoclax Rituximab can be reused after 5 years, 7 years when the disease comes back because there's nothing like resistance. Even on the front of infection, there is a major difference between BTKI and BCL2I. The BCL2 Venetoclax, if I take first, the infections are totally connected with neutropenia. And as I mentioned, that's manageable. It's preventable. You can very carefully titrate the dose of Venetoclax or even stop it for a while or use GCSL. So Venetoclax neutropenia and infection is in your control. The same thing is not true with BTKI. So when you're giving Acala, there is a decrease in the T cell function. The T helper cells, there is a decrease in the NK cell function. There's a decrease in the monocyte function. And there's a decrease in the macrophage function. And these things are cannot be assessed or calculated in the clinics. So these patients get sudden infections. Now, as far as the fixed duration therapy is concerned, the core is Venetoclax. There is no fixed duration therapy without Venetoclax. And the reason for that is the BCL2 inhibitor restores the apoptosis. So Venetoclax is a very potent, highly selective, oral active BCL2 inhibitor. The CLL cells highly overexpress the anti-apoptotic BCL2, which sequesters the pro-apoptotic protein back and back to evade the programmed cell death. So when you give Venetoclax, it binds directly to the BCL2, displaces the pro-apoptotic signal to rapidly trigger the mitochondrial outer membrane permeabilization leading to apoptosis. So in short, giving Venetoclax is bringing the apoptosis back. Now, initially Venetoclax was combined with monoclonal antibody, and for a newly diagnosed patient, the monoclonal antibody was obinutuzumab. Now, please don't confuse between obinutuzumab and rituximab because for a newly diagnosed patient, when you're giving a treatment for 1 year, fixed duration, it has to be obinutuzumab and it must not be rituximab. Rituximab is inferior, we will soon see. Obinutuzumab is type 2. There are many conditions where you use rituximab in hematology and oncology, but this is one condition where obinu is far superior. So it is, and the reason for that is that the CD20 is very poorly expressed on CLL. It's not like lymphoma patients where CLL is very densely expressed and brightly expressed. So for CLL, you need a very potent anti-CD20 antibody, and obinutuzumab is that. It's a type 2 anti-CD20 monoclonal antibody. It's glyco-engineered type 2. It is designed to maximize the immune-mediated clearance. It induces direct non-apoptotic cell signal, cell death, significantly much more effectively than the type 1, that is rituximab. It enhances the affinity for FcRR3 receptors, yielding superior antibody-dependent cellular cytotoxicity, the ADCC, and the phagocytosis. So when you combine venetoclax with obinutuzumab debulks the peripheral blood. I mean, usually you start venetoclax much later because you don't want tumor lysis. So you start with obinutuzumab and you see very quickly the counts dropping from 100,000 to barely in 1,000 or 5,000. So it debulks from the peripheral blood and the secondary lymphoid structures within the initial weeks. So it lowers the tumor burden to such an extent that when you add venetoclax, there is no significant tumor lysis because there is not much tumor left in the body. Together, they target distinct complementary pathways and clear the cells both from the blood and the protective tissue niche. So the effect is actually synergistic and then whole body. Now, when I was telling you about that the obinutuzumab is not same as rituximab, it is superior. You have to look at this study, which was published just 2 weeks ago. Venetoclax combinations upfront in CLL 5-year results. And I'll show you these results. The top term is GIV, that is Gazyva, obinutuzumab with ibrutinib with venetoclax, the triplet. It's the most potent. We will talk about it a little later on. It is not standard of care because it's not required for most of the patients. Then comes GV, Gazyva with venetoclax, the red line. 5-year progression-free survival of 70%. The triplet was 80%. Then comes rituximab, venetoclax. It is 57%. So it is far inferior to obinutuzumab. And then comes chemotherapy with rituximab, which is 50% in the blue. So this is CIT, chemotherapy based. This is rituximab based. This is obinutuzumab based. And this is the triplet. From obinutuzumab, we have moved. We have now come to all oral combinations by using BCL2I with BTK2I. So I'm merging the two mechanisms of BCL2I and BTK2. So you are giving combination of venetoclax with Ibru, which is obsolete, so Acala and Zenu. And just about a month ago, US FDA approved this, venetoclax with Acala. This totally avoids the infusion-related challenges of obinutuzumab. So now you are free from infusion center. Synergistically forces the CLL cells from the protective tissue microenvironment, that is bone marrow, lymph nodes, liver, spleen, into the blood, where then they're eliminated by venetoclax. A word about MRD. So MRD can be assessed in CLL patients by multiparameter flow cytometry or NGS. Usually in the practice, you're looking at undetectable MRD to the tune of less than 10 raised to -4. So that can be done with flow cytometry. Most of the time, we do it from the peripheral blood, but you can do it from the bone marrow where it is still, I mean, you can have negative results in the bone marrow, in the blood, but you still may have positive results in the bone marrow. But then that's not practical to keep it often from the bone marrow. So usually it is done towards the end of the treatment, and this serves as the strongest surrogate indicator of the long-term progression-free survival. So those patients who receive 1 year of fixed duration treatment, and if they are undetectable MRD in the blood in the marrow, then that is a predictor for the longest progression-free survival. Now, visualizing the clonal eradication dynamics. The traditional therapy yields partial clearance, leaving a substantial reservoir of the clone behind. While the venetoclax-based combination achieves a steep vertical drop in the clonal copies across the log scale. This profound clearance resets the disease clock, driving the long-term treatment-free periods without any maintenance. So without venetoclax, this kind of treatment-free period is not possible. Now coming back to when OB, the protocol and the administration. It's a total of 12 months treatment, 12 cycles, each cycle for 4 weeks. Cycle 1st to 6 is the combination of Obinu and Venetoclax. Cycle 7 to 12, there is only Venetoclax monotherapy. It has been designed in such a way that there is a maximum efficacy in the shortest period of 1 year. So, cycle 1, we give 3000 mg of Obinu or 3 grams of Obinu in a split fashion. Day 1, 100 mg, which is like a test dose. Day 2, 900 mg. So this makes it 1 gram. Then after a week, another gram. After 2 weeks, another gram. So total of 3 grams in the first cycle. Now, from the 5th week, we add the Venetoclax because by that time, a lot of tumor has been destroyed. So the risk of Venetoclax-induced TLS significantly reduces. And then also you do it in a ramp-up fashion. Gradually increase every week from 20 mg, 50 mg, 100 mg, 200 mg to 400 mg. So this allows prevention of TLS. So that's what it is here, 20, 50, 100, 200, 400, escalating it every week level and keep monitoring the lab for any TLS from happening. The target dose of 400 mg is reached at cycle 2, day 22. And then it is maintained right up to the end of cycle 12. During this period, from the second cycle, a gram of Obinu is administered on day 1 in every cycle. Gradually, the laboratory monitoring now shifts to just doing the basic blood counts and the metabolic panel. You're no more bothered about TLS. Obinutuzumab is stopped entirely after the 6th cycle. From 7th cycle to 12th cycle is purely Venetoclax. So it becomes extremely easy for the patient in the second half of this protocol. And then you stop the therapy and just keep the patient under surveillance. In this surveillance, you're looking at the patient physically, doing the blood count, etc. So it's once again back to the watchful wait period. Here I'd like to bring in the CLL14 trial data, which was just presented in EHA 2 months ago. It's nearly 10 years data of combination of Venetoclax with obinutuzumab. And it showed that there's a sustained superior progression-free survival advantage over the control arm. Over half of the patients who received 1 year of Ven/Obinu continuously remained in remission for more than 5 years after stopping the treatment. It achieves, this combination, unlike continuous BTK, achieves a very high degree of undetectable MRD. 76% of patients in the blood and 57% of patients in the marrow have undetectable MRD on Ven/Obinu protocol. Similarly, in relapse refractory setting, you have Ven plus rituximab, the Murano trial, which is given for 2 years. And it showed its superiority over the continuous bendamustine rituximab. It achieved superior PFS and superior overall survival. And this has become an established protocol for the relapse refractory patient, that is 2 years of Venetoclax plus rituximab. Now, directly comparing continuous ibrutinib monotherapy against a fixed time duration 1 year of this protocol, it is confirmed that 1 year fixed duration when OBU or when IBRU, or from that token when ACALA or when ZANO is not inferior to continuous daily BTKI. And this is supported by clinical benefits by giving patients extended treatment-free windows. I've been telling you that ibrutinib is no more manufactured. So we have Venetoclax with Acala, and that trial was amplified trial. And with this amplified trial results, recently, just 2 weeks ago, the US FDA gave approval to this all oral fixed duration therapy. Not only this protocol gives you this kind of treatment pre-interval, even in the worst of the CLL patients, that is unmutated IGHV and patients having deletion 17p, these have produced long-term remission and these have produced undetectable MRD. So life after stopping the therapy, the TFR dramatically lowers the long-term marrow toxicity, counts remain normal, there are no side effects of the drug, the quality of life of the patient is superb, it's really normal. Real-world registries have shown very low incidence of secondary mutations because patient is off the drugs. And it significantly reduces the long-term healthcare resource uses and the treatment-related complications. Life becomes beautiful. Now, there has to be strategic patient selection. So treatment decisions are shaped by combination of the biology of the disease, patient-related factors, including his age and comorbidities, and his preference. So fixed duration therapy is excellent for a fit patient who gives value to treatment-free intervals and who wants to avoid the indefinite medication. While continuous BTK approaches may be preferred by patients who are concerned about tumor lysis risk or whose kidneys are not good enough to handle this. So patients who have got kidney problem, you probably do not want tumor lysis, so you probably do not want to give Venetoclax based fixed duration protocol. You may go for a BTKI continuous therapy. And the patients who have got cardiac issues, you do not want the blood pressure to go uncontrolled or them to develop atrial fibrillation. So then you do not give the BTKI based therapy. You go for the BCL2 plus obinutuzumab. Now, the fact is that when you're giving obinut, patient has to go to the regular daycare, have his infusions, blood drawn, laboratory monitoring, etc. While the oral combination of Acala with Venetoclax takes you away from all this. You don't have to go to infusion center. This can be done in your bedroom. So let's look at this practical case scenario. The fit young man, like what you see over here. So managing a 56-year-old man who's got the mutated IGHV, which is a better of the two. He's active, he's working. He develops symptomatic adenopathy and his IGHV is mutated. So he selects the treatment of 12 months frontline Ven-Obinu. This gives him the best chance of achieving the deepest possible undetectable MRD, and therefore he can have years and years, 5 years, 7 years of treatment-free remission. Now, after this fixed duration, if there is a relapse, because there are no drug-resistant mutations happening, you can use the same protocol again, as I mentioned it earlier. Alternatively, of course, you can go to the continuous BTK. Nothing stops you from doing that if the patient desires that. There is one advantage of MRD-driven protocols. This can sort of prevent unnecessary treatment if you have achieved the MRD negativity. And it also probably then becomes a predictor for the progression-free survival. So summary, key takeaways and the concluding analysis. The future of care for the frontline treatment of CLL is between 12 months of fixed duration Ven plus Obinu, which is a time-tested 1-decade-old protocol, which has been published recently with CLL17 study presented in EHA. It gives you the deep remission, exceptional undetectable MRD, and long treatment-free interval. And challenging this is all oral targeted options, which are very flexible, which allow the clinicians to treat the patient in their bedrooms. The data on all oral targeted options is of short duration, but it is very powerful. I'm going to end my talk with a case study. So we got Prakash. He's a 60-year-old retired CEO. He's got moderate activities. He enjoys walking and plays golf. Why did he come? He actually came for routine annual physical examination. He had noticed mild painless swelling in both the side of the neck for the last 4 months. Was his only complaint. He denied any fatigue. He denied any drenching night sweats. He denied any unexplained weight loss. And he denied any recurrent fever. So there were no B symptoms in short. Hemoglobin normal, platelet normal, WBC 42,000. Absolute lymphocyte count 31,000. Flow confirmed CLL. It was RISE stage 1, Binet stage A. As the standard is, this patient was offered active surveillance. 14 months later, his disease progressed and symptoms emerged. He developed drenching sweats and lymphadenopathy in the neck became gross. His fish showed that he's got deletion 13q, which is a good marker. And there was nothing from the angle of the bad markers. IGHV was mutated, which is good. TP53 was wild type, which is good. He and his wife were explained that he now needs treatment. He cannot be anymore on surveillance. He was explained that the chemotherapy-based protocols are obsolete. They are inferior. They give you shorter progression-free survival. They also can create problem of second cancer in the form of MDS, AML, etc. He was explained that his disease is highly treatable with targeted oral molecules and the targeted injectable antibodies. We explained them the two primary modern treatment philosophies, the continuous BTKI-based indefinite therapy versus fixed duration therapy. The continuous control pathway, daily pill of Acala or Xeno, it acts like a thermostat. It keeps the cancer asleep. The pros are highly effective, simple oral single medication, avoids intensive initial hospitalization or infusion center visits. The cons are he must take this indefinitely every single day until the medicine stops working or there is intolerable side effect. The option B was fixed duration BCL2 combo. So patient was explained that 12-month combo of intravenous antibody, Obino, and daily oral pill, Venetoclax. Pros are highly effective, 10 years data, drives exceptionally deep clearance, and completely stops the treatment at the end of 1 year, allowing him a holiday of 5 to 7 years. Cons are, it requires a structured 5-week oral drug escalation, frequent visits to look for the tumor lysis syndrome, etc. Prakash states, I want to get this treatment aggressively, but my goal is to travel and spend time in my club playing golf without feeling anchored to a pharmacy forever. So he was totally against continuous BTKI. He expresses his anxiety about the long-term financial burden of that continuous therapy as well. He is highly motivated by the concept of treatment-free interval of 5 to 7 years, where he doesn't have to take any cancer medicine whatsoever. At the same time, he was also concerned about IV infusion protocols and prevention of TLS and the specifications which go with it. So because Prakash had mutated IGHV, clinical data shows that he's an ideal candidate for exceptional durable long-term remission with fixed duration therapy. Prakash had mild controlled hypertension, and therefore avoiding the BTK inhibitor will minimize the long-term risk of developing atrial fibrillation. The clinical team and Prakash finally selected a combination of 12-month Venetoclax and a better BTKI ACALA, which has lesser chance of atrial fibrillation. And from today's token, it would have been Venetoclax with Xenu. Now, searching for the last hiding cancer cell. So we teach Prakash about ultimate clinical objective, that is reaching up to undetectable MRD. Standard blood tests look under the basic microscope, but MRD is highly sensitive to look at one cell out of 10,000. And achieving undetectable MRD acts like a reset button, predicting a very long treatment-free window. This kind of fixed duration, as was said earlier, avoids resistant mutation. Because Prakash will stop the treatment after 1 year, his remaining normal cells are not exposed to the drug pressure. So resistance does not develop. And when the disease comes back after years, he can use the same drugs again. So this gives you a sort of important aspect of what we've discussed so far. Patient preference is important. He desires fixed duration or continuous therapy, whether he is willing to visit the hospital for treatment and follow-ups, especially for injectable obinutuzumab and for monitoring of TLS. Then the disease feature. Deletion 17p, TP53, and IGH. And the patient characteristics and the comorbidities. How old is the patient? How fit is the patient? What is his cardiovascular status? Whether you want to avoid BTKI because of his heart? What is his kidney status? Whether you want to prevent tumor lysis syndrome and you don't want to use drugs which can cause TLS like Venetoclax. History of infection and immunosuppressed people, because you know that the infection by BTKI are unpredictable as against neutropenia of Venetoclax, which is predictable. And lastly, the logistics. Which drug is available? Patient is suitable for the hospital-based treatment and monitoring, and the capacity of the hospital to provide the TLS monitoring. There are some secondary influences on the treatment selection. Patient's attitude to IV therapy versus oral. Patient's attitude to a particular type of side effect. Some people don't want even diarrhea and fatigue. Disease feature, the overall tumor burden, because that will decide the degree of tumor lysis syndrome and whether the patient has got complex karyotype. Patient's characteristics and comorbidities. What are the drugs he's taking? If he's on warfarin, he's on double antiplatelet agents, you would like to avoid BTKI. And then the logistics. Which treatment the patient is likely to be most adherent, because adherence is important in achieving the best outcome. So with lot of FDA approvals, we have a plethora of protocols with which you can treat the patient in a fixed duration method today. So fixed duration therapy is not just straight away Ven Obinu. You have Ven Obinu for a newly diagnosed, you have Ven Rituximab for a relapsed patient, and I would say a person who cannot afford Obinu but is a candidate to receive monoclonal, Venetoclax Rituximab. Then you've got all oral combination, Ven Ibru, which is obsolete, Ven ACALA, which is very popular, Ven Xenu, which is becoming popular and will be replacing ACALA. And then in the worst of the patient, IGHV unmutated, TP53 aberrated, those kind of patients, probably Venetoclax, I may replace Ibru with ACALA and obinutuzumab. So this is the summary. Venetoclax Obinu, best and time-tested, approved. Venetoclax Rituximab is inferior, only for relapsed patients. Ven Ibru is obsolete. Ven ACALA, best approved, short follow-up. Ven Xenu may be the best and will be the best, and one day will replace ACALA with its wide availability. And Ven Ibru obinutuzumab for the poorest of the poor risk patients. So friends, what we talked in last 45 minutes is how do you balance patient factors, disease factors, and the treatment factors, achieving a very balanced view what is best for your individualized patient therapy. No two patients are identical, no patient's disease is identical, and no patient's efficacy and tolerance to the treatment is identical. So you decide what is best for your patient, and you decide what is not so good or inferior for your patient in consultation with the patient. Well, thank you so much for allowing me to speak to you. The screen, and we have about 10-12 minutes for discussion if there are questions.
One question in the chat box.
Yeah, chat boxes. A question from Abhishek Mukherjee. What's your expert opinion on Zeno Sonro data? Wonderful. I mean, I didn't touch upon it because it's not in near future in India. Zeno is already with us, marketed, available. Sonro will take some time to come to India. So the data on Zeno Sonro is something which will replace Venetoclax totally. So it's the next generation BCL2. The undetected MRD after 1 year of Zeno Sonro is 97% from peripheral blood and 85% plus from the bone marrow. It's minimum 2-year therapy with combo followed by Zeno monotherapy. 50% of patients are still on Zeno at 30-month follow-up, while when Obinu is truly fixed duration for 12 months. Well, I would say that if you look at the arm D of Zeno, where Zeno was combined with Venetoclax, the data is very different from what has been put up here. That is true that we have a shorter duration follow-up of this all oral combinations as against when Obinu, which is 10 years, 9 to 10 years follow-up. For high-risk subset, MRD guided when Ekala Obinu, yes, sure. When Zeno regimen showing encouraging progression-free survival rate, yes. When Ekala Obinu protocol, 80% patient could achieve undetected MRD, yes. Stop therapy at 24, maybe 12, maybe 24. But in when Zeno protocol, only 20% of patients could achieve undetectable MRD and stop therapy after 27 cycles, and 75% are still on Zeno at 30-month follow-up. See, well, these are protocols which are, and the trials which are looking at MRD. So at the moment, standard of care all over the world is not looking at the MRD. But yes, sooner or later, you will be looking at MRD, and then you will decide what is the best with respect to MRD. If the MRD shows you that, yes, achieving non-detectable MRD genuinely gives you the longest treatment-free time. So there's a lot of comments rather than questions. Any questions, any more comments?
Sir, when we are deciding about the fixed duration therapy, for example, Ekela plus Ven, there are many studies which shows 1 year, 2 year, even up to 6 years, the UK study. So they have said that if the patient is not given for up to 2 years, there is no much great benefit. Is it true? It has to be more than 2 years or maybe equal to 2 years?
There is no benefit of what? Using Ekala when if you do not use it for many years.
If you are not using for many years, minimum 2 years should be there. So if you're using it less than 2 years, then there may not be that great PFS benefit. That was a UK study for 2 to 6 years versus 1 year of Captivate study and all.
So the data on all oral combination in a way is a bit fragmented data. The longest data was with Ibru. Ekala data is shorter. Xenu data is very little. Now, what duration will be the best duration? Whether it will be 1 year, 2 year, 3 year, 4 year, and whether undetectable MRD, how much benefit it gives you from the angle of progression-free survival duration has to be all seen. We have 10-year data of when Obino. We don't have anything close to that with all oral therapy. So there we can clearly talk about the median progression-free survival of 5 to 7 years. A fixed drug, fixed doses, fixed schedule, everything is there. But here you got data with Ibru, data with Ekala, data with Xenu, and the longest data once again is for 1 year or say 14 to 15 months. But that longest is what, 3 years. So it's all too early really to say what will be the optimum duration and whether it will have to be MRD guided rather than just fixed duration therapy. If MRD guided, then it is that way wonderful that you keep doing, you neither overtreat nor undertreat. You'll not give everybody 3 years or 2 years or 4 years or 5 years. You'll just go by the MRD and maybe just by peripheral blood. But that kind of quality of MRD detection should be available next to you. At the moment, I wonder whether in India, the type of quality of MRD that we have can be trusted to decide the duration of therapy of CLL. I'm not doing that at all. And some patients we have done here, and when they've gone to one of the center in US, there's been a gross difference. In US also, they send all the samples, not at individual hospital. They send it to the Seattle. So MRD for CLL is not an easy job. And I don't think today we can say that the treatment has to be MRD guided. Duration of treatment has to be MRD guided. And by the time you may have Perto in the first line. Any other question? We have a couple of minutes, but I think Dr. Priyanka has already logged in. So we may not wait and we can start. Dr. Priyanka, is it okay if we start?
Hello, Dr. Agarwal. Yes, I am. I'm just trying to turn my video on, but not managing to do that yet. So just give me a couple of minutes.
Take your time. By the time I'll just introduce you. So the second talk this evening is by Dr. Priyanka Mehta. She's from UK. She is BSH Administrator, British Society of Hematology. She's a consultant hematologist. She's highly qualified to provide expert hematology care with extensive experience spanning benign, malignant, and lab hematology, as well as a strong focus on red cell disorders, leukemia, MDS, and MPN. Her leadership role as clinical lead for hematology at University Hospital Bristol NHS Trust and lead for the leukemia service demonstrate advanced clinical responsibility, while her involvement as principal investigator in multiple clinical trials reflects a strong commitment to research and access to innovative treatment. In addition, her lab expertise, educational supervision, and active professional memberships support her ability to deliver evidence-based, comprehensive, and patient-centered care. Today, she's going to speak to us on the real-world AML management, insights from real-world evidence, and clinical practice. Oh, okay, your video is on.
Thank you very much, Dr. Agarwal. What a kind introduction. But if I may, can you hear me okay?
We can hear you well.
if I may just add to the introduction that I'm just one of the many thousands inspired by Dr. Agarwal towards in clinical medicine. I used to be, like I said, one of the thousands of students who have had the joy of his training. And I'm also one of many, I suppose, who got inspired to do hematology because of his teachings during my days in MBBS at Sion Hospital. So it's my absolute pleasure um, to be doing this talk, Dr. Agarwal, whilst you're sharing it. So I'm going to try and share my screen. Um, and
Yes, we can see.
oh, I need to display settings.
Perfect.
So, Dr. Agarwal, I'm going to minimize all the everything, so I won't see if any hands are going up or anything. And I suppose we'll keep Q&A for the end, but I'm very
Yes.
happy to be interrupted. Um, so, I'm going to be talking about real-world AML management insights from the real world and from clinical practice. And this is the disclaimer. And I want to, whilst I'm supposed to talk about real world experience, I think it's always useful to go back and look at trial data. It's the most systematic and rigorous analysis of using a treatment regimen in AML. So I'll start with that, talk about real world experience, just because we have now had coming up to a decade of using Veneza in AML. I've got one case to discuss just to see how we can try and optimize or get past all the usual hurdles of patients on Veneza, and then talk a little bit about when and how we can reduce doses of Veneza, and some very informative tools to predict outcomes for patients on Veneza. So you have to start the talk on Veneza with the absolute pivotal trial, which was Viale A trial, which set standards for non-intensive treatment in AML by combining Venetoclax to azacitidine and showing a significant improvement in overall survival at 14.7 months as compared to AZA alone, and also showing a significant reduction in risk of mortality for the patients who were getting combined Veneza. And this was really a huge shift because until the combination came about, our older and unfit AML patients were really resigned to largely supportive and palliative care with no real chance of long-term survival. But if you follow this long-term follow-up of VLA patient graph, you can see that the curve is still sort of trending down and it's not really plateauing. And this is going to be relevant as we talk about it a bit more later. What about response rates? Again, Veneza was showing a striking improvement in CR plus CRI at 67% as compared to AZA alone. It was showing a very good improvement in red cell and platelet transfusion independence at about sort of 50 to 70%. And as we began to see a good response rate for our older, frail patients, remission rates of 67%, we thought that, can we be using it on not so old and frail patients? But then it became important to understand how good are the remission rates, how deep are these remissions. And so we have this data shown from VLA trial that clearly MRD matters, even if you're using Veneza, that for patients who become MRD negative, and this is flow cytometry, MRD of 1 in 10 raised to the power of -3, and you can see the top curve is for patients who've achieved MRD negativity, and then this green curve is much lower for patients who don't achieve MRD negativity. Also, what we learned from VLA-A, this was presented by Keith Pratt's paper, showing that actually for patients who do achieve MRD negativity on Veneza, which is about 62% of patients, only about a quarter achieve this by end of cycle 1. Another quarter achieve it by the end of cycle 4. Another quarter by the end of cycle 7. And you still have about 20% of patients who only achieve MRD negativity after cycle 7. So it is less predictable. even if now we know that MRD negativity is important to predict a better overall survival. What else did VRA show us? Well, it did a subgroup analysis as you would in AML, but clearly there was a benefit of Veneza across all the demographic distribution of age and sex. Also, cytogenetic risks, it seemed to be better. Where it was quite informative was that there were certain genetic subtypes like the IDH1, IDH2 mutated and NPM1 mutated who seem to benefit a lot more with Veneza. And this was VLA-A trial, and again, very informative. But like I said, now we have had about almost 8 years of real-world experience with venetoclax azacitidine. So we had Andrew Way put this data in a very, very useful paper in Blood called "How I Treat Patients on Veneza." And he put together this chart, and the top line is the VLA-A patients, 286 patients, median age 76, 66% CR/CRI, and a median overall survival of 14.7. But you can see all these are different studies with, somewhere between 50 and 500, 600 patients in each study reporting real world experience. Again, the median age is somewhere in the early 70s, and CR/CRI rate also coming close to what was reported in VLA-A at around sort of 50 to mid 60s. Median overall survival, however, was 14.7 in VLA-A, and but somehow seemed to be a bit less in real world experience, sort of ranging from 7 to 12 and 13. And what was noted was that really a median time on treatment was 7 months, but in the real world, a lot of patients were dropping out earlier, and the average time on treatment was 3 to 4 months. And this really brings us to questions about why the outcomes in real world less good than what we had seen in VLA. Is it to do with our patient selection? Is it about disease being resistant, which shouldn't be the case? It's very, trials are meant to be fairly representative. And is it about treatment related complications that happen more in the real world than that might have been picked up in clinical trials? Or is it the compliance with treatment? And so this brings me to discussing this 70-year-old patient we have treated with Veneza, just to take us through things in a stepwise manner in terms of how we approach and manage these patients. So this is a 70-year-old male diagnosed AML. He's NPM1 mutated and FLT3 mutated, has 89% blast in the marrow. He's a ELN 2022 risk intermediate and a ELN 24 benefit. And I'll talk about this when I'm talking about risk categorization. He's an intermediate risk. His benefit is intermediate. He's got a performance score of 2 and SCTCI score of 5. I know we don't we're now encouraging clinicians to, particularly when you have sort of high 60s, early 70s, and you're not sure if they are transplant candidates. It's just nice to get a functional testing and not exactly a geriatric assessment, but a fairly thorough comorbidity index scoring and performance scoring using the HCTCI. So he had a HCTCI score of 5, and he'd been a smoker, 70-year-old with hypertension, some COPD, AF, high cholesterol, a peptic ulcer that needed treatment, and a left ventricular ejection fraction of 52%. He was on the usual cardiac medications, but he was moderately active, although he lived alone, which is always a consideration when you're trying to treat older patients with AML on chemotherapy. But he had some support with his two grown children who live locally, but because of his comorbidities, he was clearly ineligible for intensive chemotherapy. And as I said, he was FLT3 mutated, so he presented with a high white count and anemic and mildly thrombocytopenic with 88% blast, even in peripheral blood. So we did some cytoreduction by hydroxycarbamide, managed to bring the white cell count down to 11 just before he started his first Veneza cycle. And this is obviously with a view to reducing the risk of tumor lysis, which can happen with venetoclax azacitidine. Fortunately, we don't see it as often in AML AML treated with venetoclax, as I suppose you see it in your lymphoid malignancies treated with venetoclax. But in this patient with a high white count, obviously that would also have been a concern. I'm just talking about this a bit more because I'm not actually going to deal with TLS in our patient management. I'm talking more about the usual complications with Veneza, which tend to be related to neutropenia. And this is really just a diagrammatic representation of first cycle that a patient gets, talking about pre-remission maneuvers, early bone marrow biopsy, and then some post-remission maneuvers to try and mitigate the risk of neutropenia. And the first maneuver at the time of presentation is really about optimizing your anti-infective prophylaxis. And so let's see what VLA-A did. In VLA-A, anti-infective prophylaxis was required in about 80% of patients, in a large proportion of patients. But when it comes to CYP3A inhibitors, 80% of patients actually did not receive antifungal CYP3A inhibitors. And as per we know that fluconazole, ciprofloxacin are moderate CYP3A inhibitors, but drugs like posaconazole and voriconazole, which are in routine practice for us for antifungal prophylaxis, are strong CYP3A inhibitors. And so we have to dose modify venetoclax depending on whether we are using these drugs. In VLAA, only about 22% of patients on Veneza received a CYP3A inhibitor. That too, majority had a moderate CYP3A inhibitor, and some also had a strong one. And the median duration for use of CYP3A inhibitors was 12.5 days. Did it actually change anything for the patients? Well, actually, it was quite reassuring that irrespective of whether the patients had a concomitant CYP3A inhibitor or not, their outcomes in terms of response, depth of response, and the median time to response were same, whether they had a CYP3A inhibitor or not. So this was a useful outcome from VLAA, assuring us that even if we did need to use antifungals and dose reduce, it was not going to adversely affect the outcome on Veneza. What happened to our patient? Course 1, day 21, he gets a high temperature. He gets started on broad spectrum IV antibiotics. For us, first line is tazocin for patients who are not penicillin allergic. And he has a bone marrow biopsy, which is completely empty, but it's quite nice to see that there's no blast. And this really allowed us to stop the venetoclax on day 21. Fortunately, also the patient becomes afebrile with 3 days of antibiotic use. And you can see that the bone marrow has been done on day 21 of course 1. And he's still anemic and he's still cytoneutropenic with a white cell count of 0.78. But luckily has recovered his platelets. And so let's talk a little bit about this day 21 marrow. Where does this recommendation come from? Because VLA-A protocol was doing bone marrow biopsy at day 28, which is very much what we were doing for all our AML patients in clinical trials. But then ELN 2022 came up with the recommendation of day 14 to day 21 of cycle 1 for patients treated with Veneza. And this Andrew Way's paper of How I Treat last year again recommended day 21 of cycle 1. And the reason for doing this is also it allows you to decide what to do next with your patient towards the end of your cycle 1. Clearly, if there is disease persistence, more than 5% blast, you just continue with the venetoclax and just proceed with your cycle 2 without any interruption. But if your patient's got less than 5% blast at day 21, but they are cytopenic, then VLA-A said to wait up to 2 weeks. ELN 2022 said wait up to 2 weeks, which is go up to day 42. And Andrew Way's paper also said whole venetoclax, allow count recovery, neutrophils of over 1 and platelets of over 50. And that's what we tend to do. Obviously, sometimes you get cytopenias that go beyond day 42. And if you're really worried, you do have a look at the peripheral blood to see if there's any circulating blast, or if need be, do another bone marrow biopsy. Our patient's clinical course, day 28, he was still cytopenic, so we postponed the cycle 2, but fortunately by day 42, he had a full recovery. We had already done the marrow, which had shown, I should ideally say CRI, because he was quite cytopenic. So when ASA was continued, he proceeded to cycle 2. And after cycle 1, when he's cycle 2, he didn't really have any significant cytopenias. Cycle 3, he again began to have get cytopenic with a neutrophil count of less than 0.5 and a platelet count of 62. Again, we do peripheral blood and there's no blast, so we stop the ven and allow for count recovery. And the same thing happens in cycle 3. And then sequentially, we do reduce the duration of Venetoclax. I think in this patient eventually went to 14 days of Venetoclax based on his cytopenias in subsequent cycles. At this point, I'd like to say that for these early trials, we do really use GCSF to manage the post-remission neutropenia, as was done in VLA-A for over 50% of the patients. And the duration of neutropenia with GCSF is 12 days, without GCSF is 21 days, which is quite a significant difference. And you can really use pegylated or non-pegylated GCSF. And again, reassuringly, VLA also showed, because traditionally there was always this concern about using GCSF in a patient with AML, because you wonder whether you're going to mobilize, leukemic stem cells and, bring on a earlier relapse. But I don't think there's been plenty of other evidence to show that, you can use GCSF, because the risk of morbidity and mortality with prolonged neutropenia is much greater, and mobilizing leukemic stem cells is a bit of a hypothetical issue. And VLA-A showed that survival with or without GCSF was about the same as was duration of remission with or without GCSF. In fact, it's a bit superior with the use of GCSF, just suggesting that GCSF allows you to maintain your intensity of treatment, getting on with subsequent cycles, and so you might improve outcomes in that manner. What happened to our patient? Cycle 4, day 1, he has we know he's got CR with hypocellular bone marrow. He's had GCSF. We postponed the cycle 4 until count recovery, do 21 days, and then subsequent cycles do 14 days to allow for decent count recovery. And he's continued on Veneza. He was NPM1 positive, so even managed to get a deeper molecular MRD result, and he was negative after cycle 4, which adds another layer of assurance in terms of dose reduction. But then the patient continues on further cycles. He's at 21 and remains in complete hematologic remission and is MRD negative by PCR. So that was clinical trials. That was all about VLA-A. And like I mentioned, Andrew Way's paper with all the real world data. So I picked on a couple of centers, real world data. And this is Revive from Israel. And this was sort of the first prospective observational Veneza real world data, and had a good number, 209 patients. And the reason I like to show Revive from Israel is because they also then split their patients into the groups that were otherwise followed VLA-A kind of regimen and were VLA-A eligible, which is the red curve, and then the blue curve, which is VLA-A ineligible patients, showing that following VLA-A protocol seemed to result in a better outcome. And it was also about patient selection in VLA-A. What Revive also showed is they mapped out what was, the cycle duration for patients. As you can see in the initial cycles, the green bars, the top bars, are about cycle duration, and you can see most patients are having somewhere between 20, the cycle duration is 28 days to 42 days. The Venetoclax duration in the blue bars, again, the first few cycles is about 25, 28 days, and then varies from 14 days to 28 days, and then 14 days to 28 days, and quite a few subsequent cycles. And really, their sort of one of their conclusions was that median duration of Ven was 25 days and was highest during the first 3 cycles, and then it dropped off to a median of 14 days in subsequent cycles. And now I'd like to show you the UK data. This was also, a large number of patients, 654 across 53 UK sites. Again, showing a survival with venetoclax azacitidine, which is very closely resembling the VLA-A findings. And also, I'm partly proud of this data collection exercise because we did it during the very difficult COVID years where we were all cooped up in our own homes, still trying to fill in Excel sheets and entering data on patients. And what the UK data also collected was what was the experience of, hospitalization and resource utilization in these patients. And the tall purple bar is cycle 1, the lighter purple bar is cycle 2, the green is cycle 3, and orange is cycle 4. And you can see that whether it's hospitalization, ICU admission, IV antibiotics, platelet transfusion, red cell transfusion, majority of that is really happening largely in cycle 1 and some of it in cycle 2, but subsequent cycles tend to be much less dependency on hospital resources. So then we also looked at, let's look at the dose distribution and our use of antifungals. And we showed that, majority of our patients, 96% in cycle 1, 95 cycle 2, again, all over 90% full dose in at 100 milligrams, because we are mandated by NICE in the UK to use an antifungal along with Venaza to reduce our doses to 100 milligrams. But you can see that the median number of days of venetoclax we have used is 24, 28, 28 days in the first 2 cycles, and then 21 days in subsequent cycles. And this again might go to explain why our survival advantage or survival matches more closely to VLA-A. And another reason for thinking hard about the duration of our venetoclax dosing and the dose intensity of Venaza is because now the boundaries between intensive and non-intensive regimes are blurring. In the past, when we first started using Venaza, it was all about just the elderly and the frail. But now we are using it for a cohort of patients who may just have even been eligible for intensive chemotherapy. And that's why it's really a good time to think hard about our venetoclax dosing. I mean, I'm sure most of you have heard of the paradigm study, which was shown at ASH last year by Amir Fati, which was a randomized trial, phase 2B, intensive versus non-intensive. I'm not allowed to show it here because of compliance reasons. But, this is what I mean by saying that the boundaries between intensive and non-intensive are blurring. And hence, it becomes really important that we think about, venetoclax duration, 7 days, 14 days, 21 days, 28 days. So to answer that question, there was a very interesting session at EHA, which was literally last month. And this was the first prospective randomized phase 2 trial of 28 days versus 14 days of venetoclax, along with azacitidine for 7 days in a genomically agnostic AML patients over 60 years of age. And this was an American study presented by the Blood Cancer United group, presented by Uma Borate. And this trial design. Like I said, this is the first randomized comparison, and that's why it's an important study. Randomization between AV28, which is venetoclax 28, versus AV14, which is venetoclax 14. 169 patients, and their endpoints were CR across the first 2 cycles. And there were several secondary objectives, usual composite remission rates, progression-free survival, count recovery, safety, toxicity, etc. So their clinical outcome, best response across 2 cycles, showed that their CR/CRh rate were very similar between AV28 and AV14. And the overall response rate and composite CR was numerically higher in the 28 days Venetoclax as compared to 14 days Venetoclax. But all in all, a fairly good overall response for in both arms, really. With a composite CR rate, just like in VLA of 68.6%. And then they looked at subgroup analysis and they showed that, there was a much higher CR rate of patients with NPM1 and IDH2, which may have actually given this really favorable outcome for the AV28 arm as compared to AV14. And they looked at the other genetic subgroups, P53, again, not much difference between the two arms. And but you have to take into account that all the subgroup analysis are based on small numbers. So we have to be a bit careful about over interpreting. What about safety and count recovery? Because that can be the real reason why, we choose 14 days over 28 days. And they showed that most of the adverse events, hospitalizations were similar in both arms. There was not much difference in the neutrophil and platelet recovery after 2 cycles for patients who were in CR. And although there was numerically slightly better neutrophil count recovery and platelet recovery in the 14 group, I'm sorry, and the patients treated with Venetoclax 14 days. Survival. Um, the black line is AV28, and you can see that superior progression-free survival for 28 days Venetoclax as compared to 14, and overall survival also is superior with AV28, AV14, and early mortality was not different between the two arms. And so they concluded that, the way the statistical analysis was planned for the study was actually quite hard to comprehend. And so it was about showing non-inferiority for AV14. So AV14 did not demonstrate non-inferiority, which essentially means that AV14 is inferior to AV28. But the authors also acknowledge the fact that AV28 superiority was driven by NPM1 and IDH2 mutated patients. So, and there was a genomic imbalance in the two arms, which makes your sort of broad interpretation a bit challenging. His toxicity profile was good to note that it was similar, but treatment interruptions were more frequent in the Venetoclax 28 arm. And essentially, they were like, the authors were highlighting the importance of a randomized trial and trying to caution everyone against, when duration adjustment without good prospective data. And particularly as we go forward using Veneza in our relatively younger, fitter patients as well, and we go forward designing our clinical trials with triplet combinations. So this study was very important from that regard. Now, in the same session at EHA, we had this OPTI-AML, the American study, and then we had the Nordic AML group. So a European approach to lowered intensity venetoclax azacitidine. And this is the LD-VENEX trial, and this was prospective, but it was not randomized, and it was a phase 2 trial at 15 Nordic sites, 152 patients, and this was their trial design, which was a 28-day cycle, where cycle one, each cycle is 28 days, and you give 7 days azacitidine as you would. You do venetoclax of 14 days in cycle one. You do somewhere between 47 and 14 days in cycle 2 to 3. And then if the patient's in remission, you do 7 days from cycle 4 and beyond. And the comparator trial was using same doses of azacitidine, but venetoclax obviously was either 28 days or 21 to 28 days. So this was a Nordic AML group study. And what were their conclusions? They used it in all frontline and relapse setting of AML. And here they put it alongside their trial finding alongside VLA-A and real world. Median age is about the same. Response rates, low dose venetoclax 70 CR, CRI, CRH as compared to 66 in VLA, as compared to range of 45 to 68 in the real world. And the median overall survival, again, they demonstrated a very good median overall survival of 15.5 months as compared to VLA of 14.7 and a range of 7.9 to 13.6 in real world. And 30-day mortality was very acceptable at 3% in the low dose venetoclax arm. A certain V is the sort of a very interesting trial on the block. This is about using an all oral combination of oral decitabine with venetoclax. And you will have seen the NEGM paper by Goel Robos talking about an all oral combination. And again, very interesting findings. And so the Nordic trial conclusion was that they think for de novo AML, you still achieve 70% composite remissions and a median overall survival 15 months. It's still very encouraging for secondary AMLs as well, with CRs of 52% and overall survival 13 months. And again, they're using this combination and this approach of 14 days in relapse refractory AML and showing fairly acceptable response rates and survivals. Also, they've shown that hematological toxicity is similar or slightly reduced in the venetoclax 14-day arm, and also that this can be easily done in an outpatient setting, even in cycle 1. And they talked about significant cost reduction, which remains a significant issue in Europe and UK in terms of our studies and trial designs. So this brings me to talking about predicting outcomes on venetoclax azacitidine, because like I said, we are no longer talking about just elderly, unfit patients, Veneza. We are using it in younger patients, potentially patients who might have in the past been fit for intensive chemotherapy. So it becomes important now that we are able to tell patients what their outcomes might be like on Veneza. And some of these patients, we are even trying to take them to transplant. In fact, quite a few. It's becoming so interesting that we have now got so many clinical trials designed which are looking at intensive versus non-intensive, and hence these prognostic calculators for using the data from patients who were treated on low intensity becomes important. So the first of its kind was the ELN 2024 risk stratification, which was a very quick and easy based on 4 genes risk stratification. So you need data, your P53, FLT3 ITD, KRAS, and NRAS. And the overall survival risk stratification, the top line was high benefit with Veneza. These were the patients who didn't have any of these 4 mutations, no P53, no FLT3, no KRAS and RAS. And then you had the lowest benefit was patients who were P53 mutated, and intermediate benefit was, any of these mutations except for P53. And you can see here the chance of CR, CRI for patients who are higher benefit, achieving a CR, CRI of almost 80%, intermediate benefit up to almost 60%, and the low benefit is just about getting to high 40s. But because this ELN 2024 was just based on 4 mutations, it wasn't actually taking into account karyotype or any of the other biological features of AML. Comes along uh, another risk calculator, which is called the PRISM, which as you can see, is for all patients who were receiving low intensity chemotherapy, either azacitidine or low dose Ara-C combined with venetoclax, in almost 2,000 patients, so much larger group. And as you can see, this calculator is using the full genome mutational profile, myeloid mutational profile, using the karyotype as well, and some clinical features like age and whether the patient is known to have secondary AML or not, and what the sex is. And the Prism did a training cohort and then internal validation and external validation in preparing this calculator, and then showed that the overall survival stratification was hugely improved on the 4-gene classifier. So the 4-gene, the intermediate and the favorable were merging, and in fact, the same group of patients, when put through Prism calculator, shows a distinct segregation of the low, moderate, and high risk patients. And also, it showed that almost 50% of what was favorable in overall in the 4-gene calculator had actually moved to intermediate or even adverse risk. So if there is one of the take home messages from talk today is really this, the website of Prism calculator, which I've started using quite regularly in my clinic, because, you get an elderly patient or a patient you can't decide between intensive, non-intensive. You just put all your patient demographics, you put their genetic profile, whether they're secondary ML or not, and it comes up with a risk group survival, and it tells you where your patient is. It tells you what the 2-year overall survival, median survival, 12-month survival, 3-year survival. And very importantly, if you were thinking that your patient may be a transplant candidate, you can also click on this tab which tells you how your patient might do with a transplant. So it's quite a helpful tool in being able to predict what the outcomes will be, especially if you were thinking that this patient may not be fit for intensive and you want to see how they might do with non-intensive, particularly if you were also then going to take them to transplant. So I would just like to conclude by saying that even if it's non-intensive treatment, genetic testing is quite necessary to guide the frontline treatment and to inform prognosis to the patients. I would say in terms of managing Venetoclax azacitidine, day 21 marrow has become a very standard practice for us in the UK. It allows us to make all these decisions about holding the cycle and dose adjustments once we are sure that there is no residual disease on board. We do consider antifungal prophylaxis on a case-by-case basis, but nice approval for us in the UK is that we are mandated to use posaconazole, so we have to do that. But certainly if the patients are at risk of any hepatotoxicity or there's any other concerns, we do stop it. Again, day 21 marrow allows us to use GCSF in responding patients, also because it allows us to maintain some dose intensity which is quite important in the early cycles, at least up to cycle 6, cycle 12. It's quite nice to maintain that intensity and duration of venetoclax azacitidine. And again, even if they are low intensity patients, we do think MRD monitoring helps, because it helps you to guide again your treatment intensity and make plans for transplant if your patient is transplant eligible. And then I put a very open-ended statement here, individualizing treatment for specific considerations, essentially saying that each patient is just so individual, and their circumstances, their disease biology, and their personal preferences really guides treatment. So, although we do these talks based on clinical trials and real world data, these are important to have in the context when you're applying it for those individual patients with very specific circumstances. And then lastly, clinical trials and real world evidence does suggest that optimizing dose intensity does help you improve outcomes. So with that, I will finish. This is a slide just showing the Bristol Suspension Bridge, which is like a tourist interest spot, and 2 different times of the year. We have the balloon festival in summer, and then over winter when it gets all very, with the fog, it becomes quite ethereal and pretty. I suppose the only pretty thing in Bristol, so I thought I'd show it anyway.
Thank you, Dr. Priyanka. Wonderful. Enjoyed listening to you and learned a lot. A lot of our colleagues who have logged in, and some are as delegates. They can put their question in the chat box, and we have people from all around the country. Maybe you can put raise hand sign to know who wants to ask anything. Meanwhile, can I ask you one thing? What is the impact of M4 and M5 in the success of Veneza?
So I think that's a very relevant question, Dr. Agarwal, because we know from initial studies that there are some concerns that monocytic, monoplastic AMLs might not respond as well to venetoclax-based regimens. And again, this has been shown. Um, and all I would say is that if your patient is elderly and frail, you don't have an option but to still go ahead with that regimen. But if you had a younger patient who was fit, then maybe we might think differently about using intensive rather than non-intensive regimens. But I think people have gone ahead and done a lot more work in terms of resistance to venetoclax, and it's really about the KRAS and RAS mutations, which are the more sort of strongly indicative of venetoclax resistance.
Right. Thank you so much. We have a question in the chat box. Abhishek Mukherjee, do you see any issues related to patient's outcome if azole is always added to reduce Ven dose requirement throughout the treatment period?
So, again, a very good question and very relevant. As I mentioned, in the UK, the NICE has only approved use of venetoclax azacitidine alongside posaconazole. So, we are mandated to use posaconazole. And, you know, the UK real world data, which had more than 600 patients. So, I'm fairly confident. And all those patients will have received posaconazole, voriconazole, which are both the strong CYP3A inhibitors. And so we have used lower doses of venetoclax concurrent with that azole use. And we have shown outcomes which are just as good as VLA-A. So I would just like to reassure you that if you are having to use azoles and having to reduce venetoclax doses, it's still absolutely fine because there's just so much pharmacokinetic work done in terms of the levels of venetoclax achieved for patients who are on azoles or any CYP3 inhibitors. And in fact, I would say that Andrew Wave would say that if they are on the strong CYP3 inhibitors rather than 100, you should be using 50 or 70 milligrams venetoclax. But of course, it all depends on whether your patients really need the azoles and they're tolerating the azoles as well, because there's not insignificant hepatotoxicity with it.
Thank you. There was a little paper from France about 7+7 protocol, venetoclax only for 7 days. Your comments on that?
Yes, again, very interesting study, and it was one of the first sort of reassuring data on using much lower doses, duration of venetoclax. But of course, it was an observational study, and one has to be careful about observational studies with a small number of patients. I think what was really helpful in that study is that it told us even for these very old and very frail patients where we were just so worried about using 28 days and even 14 days venetoclax, we could use smaller doses and get away with it. I think what is going to become very apparent in time to come is this selection, like the OPTI-AML trial, 28 days versus 14 days. Again, if you have NPM1 IDH2, they're doing brilliant with 28 days. So maybe if you didn't have those mutations, then you wouldn't be doing any harm if you reduced it to 14 days. But equally, if they had NPM1 and IDH2 and you gave them 28 days, you might negate the need for a transplant. So I think in time to come, it'll become a lot more about a biological stratification to say which patients should have 7 days, 14 days, or 21, 28 days.
If you're a young, fit person and with the ASA, when you achieve a MRD negativity which persists for a long period, the result of transplant will be identical to what you achieve with 7+3?
Sorry, Dr. Agarwal, let me recap that. I'm not able to see the chat. Is this a question in the chat?
No, it is not in the
Oh,
chat. I am putting.
okay, sorry.
Uh, what I said is that if you achieve a MRD negativity which is lasting for say 12 months with azaven in a young fit person, then the outcome of transplant, is it identical to what you achieve with 7+3 induction?
So this has been published in Courtney Denardo paper on use of transplant in Veneza treated patients. And all I can say at this moment is if patient is MRD negative, then yes. But you're talking about MRD negativity at 12 months. And one is always worried because all the data on MRD negativity benefit transplant has come from intensive chemotherapy treated patients where we were hitting so hard with intensive chemotherapy and taking them to transplant in 2 to 3 months' time. And so you don't know these mechanisms of clonal evolution and escape at what time point it happens. You are still monitoring the same MRD, either the NPM1 or the flow at 12 months, but we do not know whether at what point that clone has actually shifted and is going to evolve, and whether the transplant outcomes are going to be identical or not. So theoretically, yes, um, it should be the same. But I would say that also maybe I should do a disclaimer here that we are doing very large randomized trials, so I don't want to give a outcome prejudging the outcome of a trial. We're doing intensive versus non-intensive and want to see outcomes after transplant. So I would just say wait to see our trial outcomes.
Sure. Question in the chat box. Arnab Das, role of FLT3 inhibitor in a FLT3 positive AML. So triplet, when AZA and FLT3 inhibitor.
So again, a very good question because we know Venaza works for FLT3 mutated patients as well, and that was shown in VLA-A. But clearly, there's been just so many studies with using almost 5 different types of FLT3 inhibitors and combining them with Venaza, and all have shown a benefit in terms of depth of remission, etc. The trouble is, are we don't have, again, we are waiting for phase 3 randomized data results to come through to tell us, and none of this is approved in the UK. So I personally haven't got an experience of combining a FLT3 inhibitor with Venaza because they are not approved. Yes, but when we have patients on Venaza who are FLT3 mutated and they relapse, then I can use gilteritinib. But so no personal experience, but the data of combining FLT3 inhibitor with Venaza is definitely very encouraging. And if you had a younger patient whom you needed to use Venaza and add in a FLT3 inhibitor, I would absolutely do it. Okay,
Dr.
now I
Kishore,
can see the chat. There is another one.
Kishore Kumar, your center wants to ask any question.
Good evening, Dr. Chandra here. Good evening, ma'am.
Good evening.
Go ahead.
Ma'am, you were mentioning about the MRD assessment, like guide treatment decisions based on MRD. So, what method of MRD you are pointing toward? Is it only flow cytometry or the standard recommendations like RT-PCR for various types of mutation for translocation?
Dr. Agarwal, I'm really sorry, but the question was very muffled for me, so I haven't I know it's about MRD, but I haven't actually got it.
I also
It's-
followed only one word, MRD.
Can you
Kishore,
hear me right now?
Can anyone type it in the chat?
put in the chat box. Meanwhile, we will take up some question from the chat
Ask
box.
about the MRD detection method actually. What method would be the best method? RT-PCR or NGS based method? Which would be the best method? They are
Oh, if
asking.
you've got a molecular marker, then you can use, NGS takes a bit longer, and so RT-PCR is good if you've already got a molecular marker. But if you haven't got a robust marker, and when I say robust, it's essentially NPM1, then otherwise it would just be flow marker.
Another question in the chat box is, how do you ramp up the dose of when in a newly diagnosed case, and how do you de-escalate it when you add POSA?
Okay, so we essentially don't do POSA from day one. So we go from 100, 200, 400, and then when we start POSA on day 4, then we drop the dose down to 100. And then from then on, it remains 100. And like I said, we do day 21 marrow. And if the patient is very neutropenic, which they all are, but if the marrow is clear and in remission, then we stop at day 21. And then subsequent cycles, we would do day 21. But only if the patient is not having any more than, grade 3. If the patient has any more than grade 3 neutropenia, we would then do 14 days for subsequent cycles. Majority of our patients, we manage to get 14 days in after cycle 2, cycle 3. But there are several patients who will drop down to 7 days as well based on their, but this is strictly done on the basis of cytopenias. And again, if with GCSF they recover within a day or two, then we don't count that cytopenia as significant. And I would say we like to maintain dose intensity at least for the first 12 cycles. After that, we are a lot more relaxed in terms of dose intensity, because we think we have delivered sufficient treatment. And if the patient hasn't relapsed in 12 months, then you're happy that you have pushed the clone as far back as possible.
Thank you. Dr. Nishita Shetty is there from Bangalore. Your site has any question? Meanwhile, one more question from the chat box. Role of TPO-RA in patients who have prolonged thrombocytopenia and who are in remission.
So basically, a thrombopoietin agonist, right? Using L-trombopag or romiplostin. Again, I don't have any direct experience of that, but generally speaking, there is. If your patient is just so thrombocytopenic that you are at the risk of losing them from hemorrhages, then go ahead, use it, because in the background we know from aplastic anemia studies that there is some concern about thrombopoietic agonist, perpetuating a leukemic clone. But I suppose again that risk is there. But if your patients were so thrombocytopenic that you might lose them to bleeding, then a trial of TPA agonist is worthwhile. And I suppose you're going to use it for this 1 cycle or 2 cycles, and subsequently probably going to hold back venetoclax and or azacitidine to try and allow them a good recovery.
Thank you. We also have Dr. Pradeep from Raipur. If your center has any questions. And one question in the chat box is that when you're adding azole, and it is approved in UK, you continue azole through and through, or only when the patient is neutropenic?
So just now, because our approval is only for use with azole, we have to continue through and through. Only if the patients are landing into some hepatotoxicity or any other, say, visual dysfunction with voriconazole, then we stop it.
Okay. Another question is, what do you do when a patient relapses after azaven?
So this is a bit difficult, Asa. When relapse depends on, what your aim is with that patient. If you're still wanting to offer curative intent treatment, then, you're left with no choice but to then go intensive. I mean, of course, if he's got a molecular target like a FLT3, then you can try gilteritinib, is approved in the UK for us to use in the relapse setting for FLT3 mutated patients. But for all non-FLT3, if you're still trying to curative intent, then I would do intensive chemotherapy and have a donor ready and take them to transplant. Now we also have menin inhibitors, but those are only available in trials. So you've got option for FLT3 mutated patient, then options for NPM1 mutated and KMT2A rearranged patients. So these three genomic profiles, we've got some less intensive options in the post-aza-ven relapse setting. But all the others, if you're still intending cure, then you have to go with intensive, whether using DA or FLAG-IDA, and just having a transplant ready, really.
Right. Dr. Sridhar Gopal, your center. Dr. Amiya Ranjan Naik, your center. Any questions? There's one question in the chat box that is there any role of time-limited as a when, or you need to continue it forever?
No, again, a very good question, because there has also been a paper on, stopping Ven and stopping Veneza. But again, these were observational studies, so it's a bit hard. I can tell you that we have a Victor trial in the UK, which was for NPM1 mutated patients, intensive versus Ven-LDAC. And for patients who were achieving MRD negativity on NPM1, we've stopped at 12 cycles. Now that trial has closed, and we will be reporting on its outcome. But I can tell you that stopping also will depend on how you choose your patients for stopping Veneza. Obviously, if you're stopping because they are not tolerating or they've got side effects, then there is, absolutely no question. You have to stop it because there is toxicity and it's a safety issue. But if they're tolerating, then stopping it really requires some conviction, which is that you've got a molecular marker for which they are negative, or they're part of a study which allows you to stop, and you will continue to monitor. The trouble is, we don't know if you stopped and if they re-emerged, would Veneza be equally effective subsequently? In all likelihood, no, because we know that, these Crohn's, even if the NPM1 is still there, there's going to be other things, other parts to the AML which might make them far more chemo resistant second time. So it's unlike CML, where, TFR worked and you can stop TKIs, and then when the transcripts re-emerge, you can just restart TKI. We can't say the same about AML. So when you don't have that confidence, and when ASA was your only thing working, you have to be super confident to be able to stop just now. But like I said, everyone is thinking the same things, and that data should be coming out as well in the near future. Like I said, there's already one study published on stopping Ven at 12 cycles. But again, these are observational studies, and we want to see a bit more. And more importantly, selecting the right patients for stopping when they are responding and there's no toxicity. As I say again and again, if there's toxicity, you've got a very good reason to stop.
Thank you. Are you still using 7+3 in UK? Is the next question.
Absolutely, yes. Oh my God. So, in the UK, we are very much ruled by NICE. And anyway, like I said, UK and Europe is still a little bit less moved towards Venice or non-intensive as much as the Americans. If I dare say that. I don't know if this is being recorded or not. I will not be allowed entry into the US after this. But yes, call us conservative, but we've got 50 years of faith in intensive. So for patients who we think, are going to benefit with intensive and are fit enough for intensive, we absolutely do that. And we have actually got now this Victor trial that I mentioned, intensive versus non-intensive. And we've now just planned our next trial, which is intensive versus non-intensive as well. So we want to see, the long-term outcomes of these intensive versus non-intensive. What is the chance of these patients getting to transplant? How do they do after transplant? If they do relapse, are there any differences in the relapses when someone relapses after non-intensive versus relapse after intensive? So we are not quite ready to drop intensive just yet, because like I just say, we've got about 50 years worth of confidence. And intensive is being delivered so safely now, with supportive care getting better, etc., that and I would certainly tell you, I've had a patient who was a young patient, KMT2AR mutated, not just DA, I've given him flag IDA, because, I can't deny our own UK trials like the AML 1819 that showed that flag IDA is better than even DA for KMT2AR patients. So, yeah, not quite given up on intensive yet, and we're just doing systematic randomized trials to tell us the way forward, and just selecting patients better.
Amit, your question.
Yeah. Regarding TP53 mutated AML, transplant not eligible, will you give AZA-ven or only AZA?
So, very good question. And I think biallelic P53 mutated with complex karyotype in the background, I would do ASA alone. And I would just tell them to go and have a nice time for the time that they've got left, ASA alone. But if they aren't biallelic and if they haven't got a complex karyotype in the background and if they're transplant eligible, then maybe I would even do intensive chemotherapy and take them to transplant because Veneza also does achieve CRs as was shown in VIALE-A and our real world data and the OPTI-AML as well, over 50% remission rates. But if you're telling me transplant, beg your pardon, transplant ineligible, then and it's just about quality of life, I would do ASA alone. You could try VEN for a couple of cycles just to reduce the tumor burden and then switch to ASA alone at that point. Um,
I have one more question, sir.
Yeah.
yeah.
If the patient is hypoplastic MDS high risk, high risk, with say about blast percentage about 14-15%, would you give AZA-ven?
No. Very straight answer to that. And the reason for that is we have done a large randomized, we as in not us, not me, but yes, us, and we participated in that trial called the Verona trial. And it was reported last year, which was Veneza for high risk MDS. And the trial did not reach its primary endpoint. And we have no basis for using Veneza in high risk MDS. And you tell me hypoplastic MDS, which worries me even more because, our concern with not even hypoplastic, regular MDS patients when took a very long time to recover. And just because the disease biology is different, they've just got such poor hemopoietic reserve that count recovery is so poor, which is why I'm not surprised that Verona didn't meet its primary endpoint. Does that answer your question? That was a very there was no, not much discussion.
Thank you. And regarding AML M7 with its karyotype, does AZA-ven really work in those scenarios?
So, you were saying M7, I get asked these questions about all these weird and wonderful AMLs as well as MPNs that transform to AMLs that have got a lot of fibrosis in the marrow. All I would say is these chaps do badly with anything you give them. Yeah. So unless you were planning to take them to transplant, I would almost say that, work up your transplant first before you give them anything so that, because they are never going to recover their counts, whatever you give them. And you may want to give them Azaven, you may want to give them high dose intensive chemotherapy. They tend to do less well with everything. Per se, fibrotic marrows, yes, venetoclax, just like any other intensive chemotherapy, is going to render them very cytopenic for very long time, which is partly why I'm saying, might as well work up your transplant.
Thank you.
Any comments on the maintenance therapy with AZA versus AZA plus VEN?
Oh, lovely question, Dr. Gaba. This is one of my favorite topics, actually. Intensive chemotherapy followed by oral ASA maintenance versus Veneza. And this, luckily for me, there was a study done. Again, this is an American study. They do their very fancy statistical analysis, propensity score matched analysis of large cohorts of patients they have. And they actually showed that for unselected very well matched population. Intensive chemotherapy followed by oral laser did well, as well, and in some subcategories better than Veneza. But again, this is about, again, becomes about disease biology because, if you had NPM1 mutated patient or IDH2, you would say, let's just do Veneza because, they're going to do just as well. But for your all comers, intensive chemo followed by oral laser, again, this was just, like I said, a prospective, observational, but propensity score match study. But again, very interesting because there is something to be said about, the tumor load reduction with treatment and what that rate is, which can be quite quick with intensive chemotherapy.
Thank you. Any efficacy of Ven in extramedullary disease, chloromas, and intracranial?
So extramedullary disease again remains sort of slightly evidence sparse area, I would say, because there aren't that much large databases that report on large number of extramedullary cases. So I wouldn't be able to say with any confidence, but certainly Viale A had some extramedullary, and some real world data included patients with extramedullary disease. And just like with the case with P53 mutated patients, they do badly with everything. Extramedullary disease is always going to do less well with Veneza as compared to patients who don't have extramedullary disease. But if there is no harm in trying it and assessing for response. Obviously, you'll need a PET scan or something to assess how well they have done rather than just bone marrows. CSF penetration, again, I've treated a few patients where there was a concern about CNS disease, and we still do intrathecals like you would with anyone with CNS disease or a CNS concern. They're saying now that for KMT2AR rearranged patients, even if there is no CSF disease, you should do CNS prophylaxis. So, in fact, we are doing the Evolve 2 trial, which is azaven plus or minus revumenib. And in those, it's for NPM1 mutated and KMT2AR rearranged. And we are doing CNS prophylaxis.
Right. Any data on adding Ven to 7+3?
So that's the German trial, 7+3 plus when versus no when, and we'll wait to see the results. I'm afraid it's not reported yet, um, but we did the same with Vixios as well, Vixios plus Venetoclax, the VFA study, and one has to be a bit careful about adding toxicity to intensive chemotherapy. Um, Especially if otherwise they are going to transplant. So essentially, if you're achieving MRD, if there's a subgroup where you expect them to achieve high MRD negativity, you have to be worried about what additional toxicity is going to do. And if you were going to add, as in the trials, it's always Ven 14 rather than Ven 28.
Right.
So I would just say that we have used combined venetoclax with FLAG-IDA, but that's in relapse setting. So you are literally throwing everything you've got to the patient because you got a transplant ready. You just want them to go into remission. And that is a Courtney Denardo paper of FLAG-IDA venetoclax versus FLAG-IDA. And clearly there is an improvement in remission rates and the numbers you can get to transplant and survival. So yes, there is a role for combining venetoclax with intensive chemotherapy, a little more tricky in frontline, a lot more clearer in relapse setting.
Thank you. Any data on combining Ven with checkpoint inhibitors?
So when is being combined with everything as triplets, Veneza and checkpoint inhibitors, but those are all in trials. And I'm afraid haven't got a checkpoint inhibitor trial just now, and so I have no experience with it. I have no access to it either. There's a question about IDH1 mutated patients, and we have got ivosidenib azacitidine as a combination available and approved on the basis of the findings of Agile trial. So we use ivoaza for our patients if they are IDH1 mutated. But obviously, if you didn't have ivosidenib, then venetoclax is very good as well because the Viale A trial and all subsequent studies have shown that Veneza does very well on IDH1, IDH2 mutated patients.
Right. If you are flow negative and if mutations like TAT2 or ASXL1 are still positive, how do you interpret?
So another very good question because To be perfectly honest, we do not still use ASXL1 and TET2 for MRD because they are not being validated for MRD. I will refer you to, again, I'm sorry to be a bit UK and Europe biased, but if I'm allowed to, there is a European Leukemia Net David paper. David was in memory of David Grimwade, who led the MRD work in AML. Dr. Agarwal might remember him from, sadly, he passed away, but to commemorate his work. The group is called ELN David, European Leukemia Net David, and they published a guideline on MRD, what to monitor, when to monitor, and what your standardization should be. So it's a very useful paper to say what you can use and what time points for MRD monitoring. We use molecular, we use only NPM ones, or the God, I'm so sorry. So NPM1, we use FLT3, but only in the trial setting. We have got ultrasensitive NGS for FLT3, but not as a standard. But for patients in trial, we use FLT3 for MRD, but no other mutations, unless of course they are balanced translocations like 821 or 16 version 16. Of course, you can use those for MRD, but nothing else. So we are certainly not using ASXL1 and TET2s, because tattoos can be a chip as well. It's not necessary that they are part of your leukemic clone. So, we're not really trying to eradicate them. And we don't know. We don't know is the answer. So I would really refer to that ELN David table. It's just one nice, neat table that you can sit down with your lab and tell them that this is what we are going to do.
Thank you. Other questions in the chat box are sort of repeat, so I'm skipping them. Any questions from the faculty present here? Okay, if none, then a vote of thanks from AbbVie. Are AbbVie people here? Okay, now then I'll give the vote of thanks. Thank you very much, Dr. Priyanka. It was wonderful chatting with you. Enjoyed the QA session. Enjoyed, of course, your lecture. And wonderful. Thanks for your opening remarks.
Thank you so much, Dr. Agarwal. I can't tell you how excited I was when they told me that you are chairing the session. I was like, oh my God.
Nice to
Honestly, really my privilege to be talking at a session that you're chairing. So thank you.
Thank you so much. And thanks to everybody for logging in and attending it from distance. And thanks to everybody for arranging it. Bye-bye. Good night to everybody. Bye.
Bye.